Hello everybody, I'm Dr. Riyaz Sharif and welcome to my channel. Today we'll talk about Staphylococcus aureus, that one simple bacteria that can cause anywhere between a pimple to endocarditis. And of course, we'll also talk in detail about the MRSA, which is one of the most feared organism in a hospital setting. So let's start off with the basics. That is, it's a ubiquitous organism. It's a gram-positive cocci, and it looks like a bunch of grapes. That's why it is called a staphylococcus. So staphyle means bunch of grapes, and coccus means a spherical berry shape. So it was discovered by von Recklinghausen, and it was named by Sir Alexander Oxton. Now, when you look at these particular bacteria, they form golden yellow colonies on nutrient agar. They are beta hemolytic when you grow it on 5% sheep blood agar. They can cause a wide range of infections, like I told in the starting, from localized small soft tissue infections to life-threatening infections, and it's one of the most feared organisms in a hospital-based setting. We'll look at the virulence factors of this organism. So, all of you know, this has a very thick cell wall. So that gives a basic rigidity for the bacteria to maintain its shape. Along with that, it also has some inflammatory properties as well as endotoxin-like properties. The next main virulence factor is a teichoic acid, which is basically ribitol phosphate polymers. So what they do, they allow this cocci to attach to mucosal surfaces, and it will also inhibit the process of opsonization. Third, you have some cell wall surface adhesins like the bound coagulase or the clumping factor, fibronectin binding adhesin, and collagen binding adhesin. We have a very important one, that is the protein A, which is a 42 kilodalton polypeptide. It is basically, it acts against the complement. It is chemotactic. It allows for mitosis, inhibits opsonization, and platelet damage. Few strains can have what is called as a microcapsule. So this inhibits phagocytosis by neutrophils, and it is a doubly charged, that is both negative as well as positive charges, which is very important for abscess formation. Now let us quickly recap what all we have learned about this particular virulence factors. The first and foremost, you have the peptidoglycan layer, which provides the shape as well as has inflammatory and endotoxin-like activity. Next, we have the teichoic acid, which basically helps in attachment. This is enhanced by specialized surface adhesins like your the fibrinogen, fibronectin, and collagen. Then you have the protein A, which basically allows for the inhibition of opsonization and phagocytosis. Then some of the members will have a microcapsule, which is also very important for abscess formation. Now we'll talk about the toxins. So first of all, you have the hemolysins. So alpha, beta, gamma, and delta hemolysins. What they do, they will basically act on this red cell membrane, leading to hemolysis. They can also affect the skin, that is dermonecrotic. They can affect the cells, so cytotoxic, the neurotoxic, and they have some activity against the WBCs as well. One of the most important toxins of this staphylococcus is the pentanvalentine toxin, which is basically a toxin which does not act alone, but along with the gamma hemolysin, it can damage the leukocytes, RBCs, and macrophages. So this is called as a synergohymenotrophic toxin. This is mostly important in the community-acquired MRSA infections. We'll definitely talk about MRSA, the mechanism, and the treatment as well. Please stay along. Then you have the next one, which is the epidermolytic or exfoliatory toxin. So this is responsible for one of the most important conditions, which is the staphylococcal scaled skin syndrome. It is made up of two components. One component, the ETA, is a chromosomal component which is heat stable, and another one which is the plasmid coated heat labile component. This is more common in newborns and children. So what it does basically starts with a localized blisters which can slowly convert into bulla. Once this bulla is there, on the topmost layer will slough off and there will be denuded skin underneath this particular epidermal layer. The mucous membrane is usually left off. So the milder forms are your pemphigus neonatorum and bullous impetigo. Severe form is what is called as a Retter's syndrome, which is basically comprises, apart from the toxin effect, what we already know right now, fever, lethargy, and irritability with poor feeding. Then you have the enterotoxins, which are mostly around 50% of the Staph aureus will have this enterotoxin, and they're responsible for staphylococcal food poisoning. There's a preformed toxin which can act within 1 to 6 hours, and this enterotoxin can be of 15 types, and type A is more common to cause food poisoning. The serotype F does not cause food poisoning but is associated with the next important condition, which is the toxic shock syndrome. Now we'll see about the toxic shock syndrome. Again, it's a toxin mediated disease. There are two subtypes. You have the type 1 and type 2, which are superantigens. The TST1 is a staphylococcal enterotoxin, wherein mostly it is the enterotoxin F which is responsible for this. Initially, it was thought that this particular toxin is mainly seen in women who forget to remove the vaginal tampons during menstruation. But now it is known that the TSS can arise from other conditions like staphylococcal abscess, osteomyelitis, after surgery, or any kind of a burn or traumatic infections. Now, this basically what it does, it does not go to the normal way. Since it's a super antigen, it can go and bind to the T cell. What it does, it produces a storm of cytokines flooding into the system, which can lead to multi-system disorders. So it starts with fever, hypotension, sometimes mucosal hyperemia, vomiting and diarrhea, confusion, myalgia, abdominal pain. Sometimes there can be a rash which will desquamate later. Once this effect is increasingly seen in this particular condition, what will happen? It affect other organs like liver, kidneys, lungs, GIT, and CNS. So if we look at the case definition, the clinical criteria is fever, rash, desquamation, hypotension, and involvement of at least more than 3 organs is the clinical criteria. Along with this, you need to have a laboratory criteria where there is no other organism isolated in blood culture apart from Staphylococcus. Once the Staphylococcus toxins are there, there will be an antibody protection, which is the anti-TST antibodies, mostly seen in the convalescent stage, and they will help in patient to recover. Sometimes, if this antibodies do not appear, that means the toxic shock syndrome is more severe. Diagnosis wise, you can do a latex examination for the toxic shock syndrome toxin or the enzyme immunoassay. You can do PCR for detection of TSST1 and 2 genes. They can also be associated altered liver or kidney functions and a low platelet count. So the treatment is basically you have to basically make sure that there is aggressive fluid replacement because the toxin causes a capillary leak, and you have to give on vasopressors to keep the BP properly maintained. So the hypotension, the patient has to be recovered back from the hypotension. Remove any kind of foreign body or any source of infection. And for this particular infection, the preferred antibiotic is clindamycin because it will reduce the toxin production. It can be given along with some other penicillins like cloxacillin for methicillin sensitive Staph aureus, or you have to go for vancomycin for MRSA. If at all patient is resistant to clindamycin, Linezolid can be used in these cases. Yeah. To sum up, so you have a toxic shock syndrome where the risk factors initially was thought to be the vaginal tampons where the staphylococcus grows and the toxin is produced. But now we know that it's not only that, it can be any source of staphylococcus, maybe abscess, maybe osteomyelitis, post-surgical or traumatic infection. So what it does basically, the toxin is absorbed inside. This toxin acts as a superantigen. It will stimulate the T cells to produce excess amount of cytokines. The cytokines will go and affect the systems. Mostly it is a multi-system disorder. So what happens? Patient will develop fever, hypotension, mucosal hyperemia, vomiting, diarrhea, confusion, myalgia, abdominal pain and sometimes rashes. Later on, this will also affect other systems like liver, kidney, lungs, GIT and CNS. So the case definition, you have a clinical criteria where the patient should have fever, rash, desquamation, hypotension, and more than 3 system involvement, along with the negative culture for any other pathogen apart from this particular Staphylococcus aureus toxin. When the patient is recovering, there can be a anti-TST antibodies, and if the patient does not develop these antibodies, the toxic shock syndrome is more severe. For diagnosis, you can look at this TSST by latex mutation or enzyme immunoassay. You can do PCR for the TST1 and 2 genes, and you can also have some associated laboratory parameters. Treatment-wise, you have to aggressively treat the patient with fluid replacement and the blood pressure maintenance. Examine for any kind of source of infection and deal with it. And the preferred drug is clindamycin. Okay, next we'll talk about the enzymes, the extracellular enzymes such as coagulase. The most important thing is it is a very important virulence factor. What it does when it comes in contact with blood, it will activate the prothrombin and give rise to clotting. So this converts the fibrinogen to active fibrin. The fibrin clot, which is around the bacteria, will prevent the bacteria from getting phagocytosed by our immune system. And this is also the basics for what are using for lab diagnosis of Staphylococcus aureus, that is your tube coagulase test. The other enzymes, what you have a heat stable thermonucleases and DNase enzyme, which are not produced by any other staphylococcal species like your, now you call it as SOSA, earlier it was termed as CONS or coagulase negative staphylococci. The staphylokinase is one which breaks down the fibrin clots and this helps in spreading the infection locally. They can also be hyaluronidase which breaks down the connective tissue network, and they can be lipases and phospholipases to break down the lipid component of it. So let us again look at what all the arsenals this particular staphylococcus has, that is all the virulence factors. So first and foremost, you have the enterotoxins, epidermolytic toxin, the Panten-Valentine leukocidin, the coagulase, the hyaluronidase, and some unique enzyme markers like your DNase and heat stable thermonucleases. Now we'll go into the pathogenesis. So what happens in this infection? The Staphylococcus aureus colonizes the anterior nares, oropharynx, axilla or the perineal skin. In case of any kind of a mild abrasion or there's an instrumentation, it will adhere to the tissues by its adhesins and slowly divide in the tissue. They're using the enzymes that is protease, hyaluronidase, lipases, and it will cause a local spread. It will avoid the host defense by antiphagocytic action. It will inhibit chemotaxis and it will survive intracellularly. And from there, it can spread to different areas by the blood, that is hematogenous route. So what are the infections caused? So mainly it is the skin and soft tissue infections. It can range anywhere from a very simple folliculitis to surgical site infection. So most common infections what you see is folliculitis, carbuncle in case of uncontrolled diabetics, abscess, mastitis, breast abscess, furuncles or boils. They can be surgical, post-surgical site infections, cellulitis, or hidradenitis suppurativa. So most common reason for this is chronic skin conditions or any kind of a skin damage or in people who are having poor personal hygiene. The next thing what you have is a musculoskeletal respiratory infections. So this is also responsible for causing septic arthritis, osteomyelitis, abscesses in major areas, respiratory tract infections like ventilator-associated pneumonia, septic pulmonary emboli, pyomyositis, empyema pneumothorax, nematocele in neonates can also be caused by this particular organism. Then you have the bacteremia, which is one of the main serious infections of this particular bacterium, that is your central line associated bloodstream infections, wherein your Staphylococcus aureus and Coagulase negative staphylococci are the most important members. It also is implicated in infective endocarditis and a native valve endocarditis, as well as prosthetic valve, IV drug abusers. All these people, it is one common bacteria which can affect all the groups of people having infective endocarditis. It can also result in renal infection or patients who are already having some amount of a compromise. It can also cause lung abscess and UTI. Toxin mediated, you have the toxic shock syndrome, food poisoning, staphylococcal scale skin syndrome. They can be community acquired MRSA infections, out of which 5 to 10% can be life threatening. The most common ones, you have the necrotizing pneumonia, sepsis with Waterhouse Fredrickson syndrome, and necrotizing fasciitis. Now we'll quickly look at the lab diagnosis. So gram stain, you can do, you will see gram-positive cocci in clusters along with the pus cells. If we do a culture on a basic nutrient agar, it will show golden yellow pigmented colonies. Blood agar, it will have beta lysis. The selective media, what you are going to use for this particular bacteria is the mannitol salt agar, salt milk agar, and Ludlam's media. You can take a smear microscopy from the culture which is done, which will again show gram-positive cultures, which somewhat look like this. So this is your golden yellow colonies on your left side, and the right side you see the beta hemolytic colonies on blood agar. The most important test what is used for differentiating the Staphylococcus aureus from other staphylococci is the coagulase test. You have two types. You have the tube coagulase test and the slide coagulase test. So tube coagulase test basically detects the free coagulase, where you take a small amount of colonies, emulsify it in plasma in a test tube and incubate it for 37 degrees for 4 hours. So you add the look at the test tube after 4 hours. So you look for a clot formation there. In a slide coagulase, it detects the bound coagulase or what is called as a clumping factor, where you take a colony, emulsify with a normal saline, add a drop of the plasma and mix. Look for clump formation there. So this is how your basic coagulase test looks. On the left side, you have the tube coagulase, and on the right side, you have the slide coagulase. So you can also do typing. So this is mainly done for epidemiological purposes. There are different types. The phenotypic type, which is the bacteriophage typing, antibiogram typing can be done to look at the source of infection. There are genotypic methods like your restricted fragment length polymorphism, ribotyping, pulse field gel electrophoresis, and sequence-based testing. Now we look at the main part, which is the resistance in staphylococci. So what happens here? The Staphylococcus aureus is basically affected by the beta-lactam antibiotics. So what it does, it basically takes up the plasmid via transduction and incorporates that into its genome. So what happens? This will lead to production of a beta-lactamase enzyme. So this enzyme can basically destroy the structure of beta-lactam ring. So the antibiotics which were earlier useful now will become totally useless. So that is the basic concept of beta-lactamase in staphylococci. So next comes the penicillin. So the initial part in 1941 when the penicillin was introduced, from that time this particular phenomenon is going on. That is what happens. Penicillin binds to the what is called as a penicillin binding protein on the cell wall of staphylococci. This is the chromosomal based resistance. So what it does, it basically the McA gene. Okay, so that will be altered. So that altered gene will alter the product, that is penicillin binding protein to altered penicillin binding protein 2A. So this will prevent any kind of the penicillins and cephalosporins from binding to the cell wall, and this is called as MRSA, methicillin resistant Staphylococcus aureus. So how do you detect MRSA? You can use surrogate markers in a routine laboratory, like that is your cefoxitin or oxacillin. You can do either MIC method or distribution. And for you can also look for PCR for McA gene, or you can do latex oxidation test for the penicillin binding protein 2A. That is the altered penicillin binding protein. You can look for it. Okay. Now, we will look at the types of MRSA. It's very important. That is, you have a hospital-acquired MRSA and community-acquired MRSA. When you look at this, the strains which express type 1, type 2, and type 3 are seen in hospital-acquired MRSA, whereas in the community-acquired MRSA, the McA gene subtype belongs to 4, 5, and 6. So the hospital-acquired ones are multi-drug resistance, but their virulence is low. They'll be seen most in post-operative or perioperative infections or nosocomial infections, whereas the community-acquired MRSA infections will express a much severe toxin, which is your pantan-vancomycin leukocidin, and it is seen in most invasive soft tissue infections such as necrotizing fasciitis. Now, when you look at the treatment part of it, you have a basically you have to divide into methicillin sensitive Staph aureus and methicillin resistant Staphylococcus aureus. So for methicillin sensitive, a very good choice is penicillin G, or you can use nafacillin or cloxacillin. If the patient is having only a skin and soft tissue infection, you can think of diclofenac, cephalexin, or cefazolin. The pattern completely changes when it comes to methicillin resistant Staphylococcus aureus or the MRSA, which is one of the, as I told earlier, one of the most feared organisms. So here we do not use cephalosporins except for in some cases 5th generation cephalosporins. The drug of choice here is vancomycin. You can use teicoplanin, or if it is a skin and soft tissue infection, you can consider linezolid. If it's an endocarditis or complicated skin and soft tissue infection, think of daptomycin or telavancin and quinpristin, dalfopristin. Sorry. Now, the MRSA, you can also think of antibiotics like tetracycline, erythromycin, or cotrimoxazole when there is not a life-threatening infection. So the 5th generation, what I told you earlier, we can use ceftriaxone, which is available in India, can be used against MRSA. If you don't know whether the isolate is MRSA or MSSA, then you can use a combination of vancomycin and aminoglycosides. That is, if the patient is in a high risk condition like a cardiac implant, post cardiac implant. This is one of the important topics, that is your vancomycin resistance. So you have two types. You have the V.R.S.A. and V.I.S.A. That is because of overuse of vancomycin. So the low-grade resistance is known as the vancomycin intermediate Staphylococcus aureus, where the MIC is somewhere between 4 to 8. If the MIC crosses 16, it is called as a VRSA or vancomycin resistant Staphylococcus aureus. Now, this intermediate types is because the thickening of the cell wall of Staphylococcus aureus. But clinically, whenever there's MSC more than 1, it has to be considered as VRSA only, as the chances of treatment failure is quite high. VRSA has been isolated in few parts of India. However, V.I.S.A is much more frequent, and this is basically mediated by the VAN-A gene. So from where this VAN-A gene came, that came from the Enterococcus faecalis via horizontal conjugal transfer. So there is what is called as a concept called as a fitness cost phenomenon. That is, when this kind of newer genes are incorporated, there are some genes which are slowed down, and this will slowly reduce the fitness of the bacterium as well. The treatment should be completely based on antimicrobial sensitivity report. You can think about linezolid, telavancin, daptomycin, which can be effective. Now we look at the control measures. Basically, you have to screen the hospital staff on a regular basis to look for any kind of MRSA infections, especially when there's an outbreak. We can use mannitol, oxacillin agar for this thing. And the treatment part, you can think about 2% mupirocin for nasal carriers and chlorhexidine body bath for skin carriers. Try to curtail your antibiotic usage in the hospital and proper infection control measures, and also isolate the patients from other patients and use the contact precautions. So to sum up, so basically you have a Staphylococcus aureus, which is a gram-positive cocci, and the most potent toxins are the exfoliatory toxin, toxic shock syndrome toxin, and enterotoxin, along with the pant and valentine leukocytes. The most feared ones are the MRSA, wherein you are not going to use any kind of antibiotics belonging to cephalosporin category. The MRSA, you can classify them into hospital acquired as well as community acquired MRSA. There are also slowly rising V.I.S.A and V.R.S.A, that is from where the gene has been taken from the Enterococcus species. Treatment wise, ideally for MRSA, vancomycin is the gold standard. Sometimes you can also use linezolid depending on your patient's condition. The most important topics for undergraduates which you have to prepare from this topic are toxins or staphylococci, Coagulase test, toxic shock syndrome, staphylococcal scale skin syndrome, food poisoning, MRSA, treatment of MRSA, vancomycin resistance, and vancomycin intermediate Staphylococcus aureus. I hope I have covered the topic. I've given you a brief overview. Please do like, share, and subscribe to my channel, and spread this video to all your friends who might find this useful. Thank you.